In this section, we will discuss the gastrointestinal hormones. So let's get started. So here's figure 5.12 from your text. And as you can see, there are three categories of hormones, which are each color-coded. In blue are the endocrine hormones, in green are the neurocrine hormones, and in red are the paracrine hormones. Endocrine simply means these hormones are released into the blood, then travel to the portal vein, and then exert their effect on the target cells. Paracrine means the hormone diffuses locally to the target cell. For example, histamine. Histamine was discussed in section 1 of this chapter, and histamine will diffuse from the ECL cells and then exert their effect on the parietal cells. Finally, neurocrine cells can be thought of more easily by thinking of them as neurotransmitters. This may not be technically correct, but it will help you better see how they function. For example, the vagus nerve will release GRP, and the GRP will enter the synaptic cleft, and it will then act on the G cells, and the G cells will be stimulated to release gastrin. Before we get into each one of these, understand that the substances discussed in sections 1 and 2 of this chapter, such as pepsinogen and acid from the stomach, as well as the enzymes released from the pancreas, are all exocrine. And exocrine means they are released directly into the lumen. For example, pepsinogen is released into the stomach. Acids released into the stomach. Pancreatic enzymes are released into the duodenum. So first let's talk about cholecystokinin, or CCK. Now these are produced by the eye cells in the duodenum. And these eye cells are stimulated to release CCK when fats and lipids enter the duodenum. And CCK aids in fat digestion. And it does this by causing gallbladder contraction and relaxation of the sphincter of Oddi. And what this does is cause the release of bile. And that bile will help emulsify fat. CCK will also stimulate pancreatic secretions. And as you recall from section 2 of this chapter, the pancreas will release pancreatic enzymes, much of which will help break down fat. So in general, CCK will help aid in fat digestion by emulsifying the fat via bile and helping the pancreas release its fat digesting enzymes, such as lipase. It's also important to know that CCK will decrease gastric emptying. And what this does is help the person feel more full or increase satiety because more chyme is staying within the stomach. So here again is figure 5.12 from your text. And when fat enters the duodenum, the eye cells will be stimulated to release CCK. CCK will then go to stimulate the gallbladder to contract, and then it will also cause relaxation of the sphincter of Oddi. And this will allow bile to enter the duodenum. CCK will also stimulate the pancreas to release pancreatic enzymes, such as lipase. And as stated before, CCK will also decrease gastric emptying, which helps the individual feel fuller after eating. You can also remember this function by thinking the enzymes need enough time to digest the fats in the lumen, so CCK will slow down new entry of chyme from the stomach to the duodenum. So to summarize, CCK, or cholecystokinin, is stimulated by fats, which cause the eye cells to release CCK, which then travels through the blood to cause the gallbladder to contract, the sphincter of Oddi to relax, leading to bile release. It'll also stimulate the pancreas to release lipase. So now let's do a question to apply this. A patient presents with right upper quadrant pain after eating a meal. Ultrasound demonstrates the presence of a gallstone. The clinician deduces that the patient's pain must be caused by gallbladder contraction against the stone. What is the pathway leading to contraction of the gallbladder? So this patient has a gallstone, and then they eat a meal, and then they get pain. What is the pathway for this? Well, when the patient eats a meal, fat enters the duodenum, which will stimulate the eye cells to release CCK. CCK will then act on the gallbladder to cause it to contract. And this contraction of the gallbladder would cause pain if the gallstone enters the cystic duct, which we discussed in section 4 of this chapter. So now let's talk about secretin. Secretin is produced by the S cells in the duodenum, and it's stimulated by acid and fat. And overall, you can think of the function of secretin as decreasing acidity. And by decreasing the acidity of the chyme in the lumen, it will improve the function of the pancreatic enzymes. which function best when it's not as acidic. And what secretin does is it will stimulate the chloride bicarb antiporter in the pancreas. And this will allow more bicarb to be released into the intestinal lumen, which will increase the luminal pH or decrease acidity. Secretin also decreases gastrin secretion from the stomach and the duodenum, and this causes decreased acid release. So this will also increase luminal pH and cause decreased acidity. Secretin also increases bile production within the liver itself, which ultimately would aid in fat digestion for reasons we just discussed when discussing CCK. So here again is figure 5.12 from your text. When fats or acid enter the lumen, the S cells will release secretin. Secretin will then travel through their blood and act to decrease the acidity of the chyme so the pancreatic enzymes can function better. And just understand that excess acidity is harmful to the enzymes that the pancreas releases. Now, secretin does this by decreasing acid production from the parietal cells of the stomach. It will also increase bicarb secretion from the pancreas, which will help neutralize any acid coming into the duodenum. So the bicarb will leave the pancreas. It will also act on the liver to increase bile production. So in summary, just think that secretin decreases acidity by decreasing acid production and releasing bicarb. Now let's do a question to apply this. A patient has a tumor that causes the production of excess acid within the stomach. What hormone will be released to counteract the acidity of the chyme, and where is it released from? So the patient has excess acid within the chyme due to a tumor. The acidic chyme will then enter the duodenum, and the low pH will be sensed by the S cells. So low pH means high acidity, and this will stimulate the S cells to secrete secretin. Secretin will then cause the release of bicarb from the pancreas, and it will decrease acid production from the parietal cells. So in answer to our question, what hormone will be released to counteract the acidity of the chyme? It will be secretin. And where is it released from? The S cells. Now this scenario with a tumor in the stomach creating excess acid is actually called Zollinger-Ellison syndrome. This is a gastrinoma, which causes excess gastrin to be produced, which will stimulate the parietal cells to secrete more acid. If we were to extend the question, we could ask, this patient has Zollinger-Ellison syndrome. What will be the serum secretin levels in this patient relative to a patient without a gastrinoma such as this? Now, all of the acid from the parietal cells will cause hypersecretion from the S cells. In other words, increased acid will lead to increased secretin secretion. So there will be a higher level of secretin to try to balance out the higher level of acid. So this gastrinoma will have higher levels of serum secretin than a healthy patient without gastrinoma. In fact, in a patient with ZE syndrome, this high secretin is actually a good diagnostic tool when working up the patient. Now, if we were to extend the question even further, we could ask, what is the chloride concentration in this patient's pancreatic exocrine glands relative to normal? So we know that this patient is secreting a lot of acid, which will lead to a lot of secretin release. And recall that secretin will actually cause increased bicarb release from the pancreas. And it's important to remember that bicarb release is actually via an antiporter. So bicarb exits the pancreas, inside of the pancreas, and releases bicarb in exchange for chloride. Now this question is asking about the chloride concentration within the exocrine glands of the pancreas. So secretin is acting on this bicarb chloride antiporter, increasing the amount of bicarb released into the lumen and increase the amount of chloride reabsorbed into the pancreas. So this patient within their pancreatic exocrine glands will have increased chloride relative to normal. So just to review up to this point, think of CCK as fighting fat, and it's released from the I cells. Think of secretin and its functions as fighting acid, and it's released from S cells. So now let's talk about glucose-dependent insulinotropic peptide, or GIP. Now GIP is produced by the K cells of the duodenum and the jejunum, and it's stimulated by fatty acids, amino acids, and oral glucose. And GIP aids in digestion of fats and amino acids and absorption of glucose. And it performs these functions by stimulating the release of insulin from the pancreas. And when that happens, of course, there will be increased absorption of glucose. For more information on insulin, please see our endocrinology chapter. Now, GIP will also decrease acid secretion, which, as mentioned before, when the acidity is decreased, there will be improved function of pancreatic enzymes. So let's draw this out. So here again is figure 5.12 from your text. And when thinking about glucose-dependent insulinotropic peptide, or GIP, it's best to let the name guide you and remember that glucose is in the name. When glucose enters the duodenum, the GIP will be released from the K cells. And GIP will then travel through the blood and then act on the pancreas to have it release more insulin. It can also be stimulated by fats or amino acids. In other words, foods of almost any type will increase the release of GIP. Now, GIP also aids in fat and acid digestion by being released into the blood and acting on parietal cells to decrease acid secretion. As you recall from the discussion earlier, talking about secretin, pancreatic enzymes function best when the acidity is decreased. So in summary, GIP will be stimulated by fats, amino acids, and glucose. So by decreasing acid secretion, the pancreatic enzymes will better be able to break down fats and amino acids, and then also glucose will be more readily reabsorbed because of insulin. Now let's do a question to apply this. A male comatose patient is receiving total parenteral nutrition, or TPN. Following a feeding, his insulin levels are lower than would be expected from someone who ingested the same nutrients orally. Why would insulin be lower? Now this patient is receiving nutrition through his blood instead of his mouth. Now normally, fats, amino acids, and glucose, when ingested orally, would stimulate the K cells to release GIP. However, with no enteric stimulation, there would be no release from the K cells of GIP because fats, amino acids, and glucose are not stimulating the K cells. Now, GIP normally stimulates the pancreas to increase its secretion of insulin. Glucose will still enter the blood and can then stimulate the beta cells directly, increasing release of insulin. But the amount of insulin release would simply be lower on account of the lack of GIP. So to review, we have CCK, which fights fats and is released by the I cells. Then we have secretin, which fights acids, released by the S cells. And then GIP brings in glucose, and it's released from the K cells. So now let's talk about Motilin. Now, Motilin is released from the small intestine, and the release of Motilin is increased while fasting, so between meals. Now, Motilin functions to clear the small intestines in preparation for the next meal. So when you think of Motilin, think of movement. And Motilin is responsible for the migrating motor complexes, or MMCs, but we can just think of movement through the intestines. So now we've talked about CCK, secretin, GIP, and Motilin causing migrating motor complexes, or movement through the intestines. And this is especially during times of fasting. So now let's talk about vasoactive intestinal peptide, or VIP. Now this is something that's released from parasympathetic ganglia when there is a parasympathetic stimulus, and it functions to increase fluid and flow in the intestines. And it does this by relaxing intestinal smooth muscle. And when the smooth muscle is relaxed, there will be increased electrolyte release, for example, potassium, chloride, and sodium. And water will then enter the lumen. VIP will also cause relaxation of the sphincter of Oddi, which will assist CCK. As you recall, CCK will cause contraction of the gallbladder and relaxation of the sphincter of Oddi in order to allow bile to flow into the duodenum. An important note is that VIPoma, or VIPoma, causes oversecretion of VIP, which can cause WDHA syndrome. And this just stands for watery diarrhea, hypokalemia, which makes sense because potassium is an electrolyte that is secreted in excess when VIP is in excess. And the A stands for Achlorhydria, which also makes sense because chloride is oversecreted. So here again is figure 5.12 from your text, and VIP is a neurocrine hormone and is released from the parasympathetic ganglia. Now VIP can then act directly where it is released and can cause widespread relaxation of smooth muscle. And when the smooth muscle throughout the intestines is relaxed, then there will be increased flow. And again, this is flow of electrolytes and water. And also remember that the sphincter of Oddi is more relaxed, allowing more bile to flow out. So to review up to this point, CCK fights fats, secretin fights acid, GIP brings in glucose, Motilin causes migrating motor complexes, and VIP causes fluid flow. It does this by relaxing smooth muscle. So now let's talk about enkephalins. Now enkephalins are released from neurons throughout the GI tract. So it's a lot like VIP in that it's a neurotransmitter or a neurocrine hormone. Now enkephalins will cause constriction of smooth muscle, and this will act to decrease flow into the intestines. So this is the opposite of VIP. So an important note is that opiates will act on enkephalin receptors, and this will allow decreased fluid flow, which can cause constipation. And constipation is a known side effect of painkillers such as opiates. So here again is figure 5.12 from your text, and we have illustrated enkephalins here being released from a nerve terminal and exerting its effect on the target cell. And this will cause contraction of smooth muscle, decreasing fluid flow through the intestinal wall, decreasing fluid within the lumen. So I'll write decreased flow. It makes sense why opiates which act on these receptors can decrease diarrhea, or in the case of a patient who does not have diarrhea but takes opiates, the patient can experience constipation as a side effect. So up to this point, we've talked about CCK, secretin, GIP, Motilin, VIP, and enkephalins, which decrease fluid flow. And this is opposite of VIP. So it may be helpful to think of VIP and enkephalin as a pair that do the opposite function. Now let's talk about somatostatin. Now somatostatin is produced by D cells within the GI mucosa, and it's stimulated by low pH, and it's inhibited by vagal stimulation, or parasympathetic stimulation. And just as a side note, parasympathetic stimulation occurs during the feeding process. And for more information on that, please review section 1 of this chapter. Now somatostatin will essentially inhibit release of all GI hormones. It will decrease release of secretin from the S cells, which will cause decreased bicarb secretion from the pancreas. Somatostatin will cause a decrease in the release of stomach hormones, which ultimately means there will be decreased acid production. Pancreatic secretions will be decreased, which will decrease insulin, glucagon, enzymes, and bicarbonate. It will also decrease the release of cholecystokinin from the I cells, so there will be decreased gallbladder contraction. There will be decreased release of GIP from the K cells, which means there will be decreased insulin. So as you can see, there's two ways that somatostatin decreases insulin release. It can decrease insulin release by decreasing GIP, and it can decrease insulin release by decreasing pancreatic secretions overall. Somatostatin will also decrease the release of Motilin and VIP, and this means that there will be decreased fluid flow and peristalsis throughout the intestines. So we provided the last slide so you can see specifically what kinds of things somatostatin would do, but it may be easier just to view this slide and recognize that it's produced by the D cells, it's stimulated by low pH, and it's inhibited by vagal stimulation. And it inhibits the release of essentially all GI hormones and pancreatic secretions. And by so doing, somatostatin will maintain hormone balance. So here again is figure 5.12 from your text, and somatostatin, which is a paracrine hormone, will diffuse and inhibit the release of essentially all of these hormones. So let's do some questions to apply this. A patient is administered octreotide, which is a somatostatin analog to treat her variceal bleeding. At a later visit to a different clinician, several gallstones are noted incidentally on ultrasound of the patient. The patient does not note any recent right upper quadrant pain. How might octreotide have caused these gallstones? So the patient is administered octreotide, so they're giving somatostatin analog. So essentially the patient has increased somatostatin. in their blood. Instead of memorizing everything that somatostatin acts on within the GI system, we just remember that it inhibits the release of all the hormones. And we will come back to somatostatin in a moment. So at a separate visit to a different clinician, gallstones are noticed on ultrasound. Now, what hormone mediates gallbladder contraction? Well, it's CCK. And if somatostatin will inhibit CCK release from the eye cells, then the gallbladder will be less likely to contract. So decreased CCK will lead to decreased gallbladder contraction. And as we discussed in section 4 of this chapter, if there's no gallbladder contraction, then there will be increased bile stasis, which increases the risk of cholesterol precipitating out. We also see that she does not have any right upper quadrant pain, which makes sense because CCK is typically what causes contraction of the gallbladder and pain from gallstones, because when the gallbladder contracts, it'll press the gallstone into the cystic duct. And we discussed this in the previous lecture. Now let's do another question. A male patient has had chronic diarrhea for 3 months secondary to a VIP releasing tumor. What natural hormone would normally counteract VIP? And the hormone that would normally counteract VIP is somatostatin. So you just remember what hormone inhibits everything? It's somatostatin. Normally, VIP increases fluid flow in the intestines, but somatostatin will decrease the release of VIP, so there will be decreased fluid flow. A VIPoma causes oversecretion of VIP, so normal amounts of somatostatin would be insufficient to counteract the effects of excess VIP. So it would make sense that this patient would have chronic diarrhea, or WDHA syndrome, as a result of excess VIP. So let's review all of these hormones by focusing just on somatostatin, which is released by D cells. And somatostatin will function by inhibiting the release of all the above hormones and will also decrease pancreatic secretions. So if we do an exercise, we can ask, why might somatostatin cause hyperglycemia? Well, it can inhibit the release of GIP from the K cells. This would decrease the release of insulin from the pancreas, and will also just decrease pancreatic secretions, so there will be decreased insulin overall. So somatostatin can cause hyperglycemia because sugar is not being taken into the cells as it would normally when insulin is present. Now, why might somatostatin cause bile stasis? Well, that's because it inhibits CCK release, thereby preventing gallbladder contraction, leading to bile stasis. Now, why might somatostatin cause constipation? Well, that's because it will decrease fluid flow via VIP, and it will decrease migrating motor complexes via Motilin. So let's do one last question to apply all that we've learned. A female patient eats a heavy steak with a sugary drink. What hormones would be released as a result of the fat content of her meal? Now, the hormones that are stimulated by fatty acids can be remembered by the mnemonic fat is sick. In other words, fat stimulates the S cells to release secretin, I cells to release CCK, and K cells to release GIP. So in answer to our question, what hormones would be released as a result of the fat content of her meal? It would be secretin, CCK, and GIP. Now another question would be, what are the combined effects of secretin, CCK, and GIP? Now recall that secretin will fight acid by increasing bicarb secretion from the pancreas, and it will also inhibit parietal cell secretion of HCl, and it will also increase bile production. Similar to secretin, GIP will inhibit the release of acid from the parietal cells. So we have two sources that are decreasing hydrochloric acid secretion. GIP will also increase insulin release from the pancreas. And recall that insulin brings in glucose. Now CCK will cause contraction of the gallbladder and relaxation of the sphincter of Oddi. And this will allow bile secretion to increase, allowing fat emulsification. So the combined effect of all three is to break down fat, bring in glucose, and decreased acidity of the chyme, or increasing the pH. And that concludes this section.